What's up, everybody? Dr. Rossi, shrinksandsneakers.com. I want to start out by thanking everyone who has subscribed to the channel and anyone who's liked or commented on the channel. Hopefully my responses to your comments have been helpful. With that said, if you haven't already subscribed to the channel, I'm going to ask you to go ahead and click that button now. Subscribe to the channel, help me to grow this thing, help to spread the word about what we're doing for mental health treatment, as well as to help reduce stigma associated with the treatment of psychiatric disorders. Today I'm going to tell you guys a story, and I'm going to ask you to think back. Think back to a time where you overate. You ate more food than you intended on eating. It could be at a party, it could be during the holiday season, specifically Thanksgiving is a big time where many people overeat. We can all probably think of one place or one case or one scenario where we ate more than we expected to eat. But the question is, what if these episodes occur more frequently? And what if I feel like I physically can't stop eating despite being full? Then you might be suffering from what we call binge eating disorder. Now, binge eating disorder was a new diagnosis that was added to the DSM-5, and for a long time, binge eating disorder wasn't included and didn't have diagnostic criteria. But what many clinicians observed in their clinical practice was that they found this to be like bulimia, only with the non-purging component. So the patient would kind of present like bulimia, they would binge, but they wouldn't have the compensatory behavior of purging, okay? This was first described in the 1950s by a Dr. Walter Hamburger, if you can believe that one. The guy's name was Hamburger, and that's the perfect name for a guy to be describing a disorder like binge eating disorder. So in this video, I'm going to go over everything you need to know about binge eating disorder, and we're going to cover it from top to bottom, including treatment. So the first question you probably have for Dr. Rossi is, what are the criteria that need to be met for somebody to be diagnosed with binge eating disorder? Well, as you might expect, you have to have what they call recurrent episodes of binge eating. And we obviously have to define what those binges are. So those binges are eating more food than other people in the same situation would eat. So that's how they define this idea of a binge. And then you have to have more than 3 of the following. And those criteria are: 1, eating until you're uncomfortably full. So eating until I can't eat anymore and feeling uncomfortable. Number 2, eating more rapidly than usual. So eating the food faster. Number 3, eating large amounts when not feeling physically hungry. So I'm eating despite the fact that I'm not hungry. Number 4 is eating alone due to embarrassment. And number 5 is feeling disgusted with yourself or guilty and depressed as a result of the eating. So you have to have 3 or more of those criteria. Now, the binge eating is accompanied by a feeling of loss of control. That's very important in the diagnostic criteria. You want to be sure that the person feels a loss of control, like they can't stop themselves. They physically can't stop themselves from eating. There is no compensatory behavior. Like I said, this is different from bulimia because the person is not binging and then purging, they're just binging. The binges have to occur at least 1 time per week, and the duration is for at least 3 months. So you have to have at least 1 episode per week for at least 3 months, and you have to be markedly distressed by this binging. So the person has to feel distressed about binging. Now, 40% of the patients have concern about body image. However, binge eating disorder does not require any diagnostic criteria for body image disturbing. And DSM-5 actually has specifiers to tell you how severe the binge eating disorder actually is. So they defined a mild binge eating disorder as 1 to 3 episodes weekly, a moderate one as 4 to 7 episodes weekly, and then severe being 8 to 13, and profound or extreme is greater than 14 binges per week. So now that we covered the specifiers, we covered the criteria for what meets binge eating disorder, let's talk about a little of the key facts here. Now, this is different than going out to dinner or occasionally on a holiday, say, overeating. A lot of times that will just be considered normal. So if everybody has more food than they normally would on Thanksgiving, this is within normal limits and really would not qualify somebody as having a disorder. Now, binge eating disorder actually is the most common of the eating disorders. However, we rarely catch it. A lot of times we're not screening for it or thinking about it when we're seeing our patients. But the 12-month prevalence is actually 0.44%, and it occurs in about 1% of the general population total. So that's a significant number of people. It's more common, obviously, in psychiatric patients, so you're more likely to see it in your clinic where you're practicing. You're also going to likely under-recognize it because patients rarely ever bring this up directly unless you ask specifically about it. The other key points are that it's more common in women, which all eating disorders are more common in women. However, what's different about this is there's definitely more men that also have binge eating disorder compared to other eating disorders like anorexia or bulimia. The disorder is often hidden. So a lot of times patients' families will not know that the person is suffering from binge eating disorder because they'll go to great lengths to hide the binges. For example, if I don't want my significant other to know that I'm binging, I may go binge outside of the home in my car and then throw away all of the wrappers somewhere else, right? I may put them in another dumpster. I may go through great lengths to hide these binges because, again, it's a little bit of a shameful behavior, and people don't think of it as a disorder. They really think of it as a moral failing. It's like I wasn't able to control my eating habits, even though we clearly see now that this can fall into the disordered category based on the criteria I listed above. So binges can include healthy and unhealthy food. That's another important point. So some patients actually binge on very healthy foods. Like you could binge on fruit. You don't have to necessarily be binging on tasty cakes and whatever other types of things, Snickers bars. You could be binging on something healthy like fruit. Also, patients are often obese with binge eating disorder, but not a requirement. Interestingly enough, 50% of patients with binge eating disorder are not obese, but they may be on their way to obesity if they continue the behavior. So let's take a second to talk about the neurobiology of binge eating. So how does this happen? What are the brain pathways or circuits that are activated when you're binging? So it's thought to be related, of course, to the dopamine reward pathways. So we believe that dopamine plays a significant role in binge eating disorder. The dopamine signaling increases the desire for food. And then we have also this mixture of the endogenous mu-opioid signaling that will increase the liking of food. So we think it's related to both dopamine and mu-opioid receptors and endogenous opioids. And you can see changes in the dopamine D2 receptor genes as well as the mu-opioid genes, which may predispose somebody to developing binge eating disorder. So let's first talk about how you would treat binge eating disorder with psychological interventions. And of course, as you might guess, the answer to every psychiatric examination when they ask about therapy is cognitive behavioral therapy. So one of your first line choices for changing this behavior of binging is to get cognitive behavioral therapy. So this is standard. The other one that seems to be very helpful in binge eating disorder is interpersonal therapy. And all of these therapies are designed to reduce the binge eating behaviors. So I'm doing therapy to reduce binge eating behaviors. Now, what's interesting about this is 33 to 50% of patients, so 33 to 50% of patients with binge eating disorder actually do not benefit completely from psychological treatment alone. So often psychological treatment alone with CBT or interpersonal therapy is not enough for the patient to get full remission or to relieve them of all their symptoms. So generally, psychological interventions result in little or no weight loss too. So not only do the person not get full remission of their symptoms, they also don't lose any weight, but it does seem to help in preventing further weight gain. So the next thing I want to talk about a little bit is the medication, because there's actually one FDA-approved medication for binge eating disorder. Right now, there were several others in development, but this is the one that's most commonly used, so I'm going to talk about it here. And you may have heard about this medication before because it's also used for ADHD. This is Vyvanse or less dexamphetamine. So Vyvanse is an ADHD treatment, but the belief is that it works on the subcortical structures by reducing the obsessive and compulsive behavior around binging and food consumption. So the way we think about this medication is not working the way it would be working for an ADHD patient. It's actually working again on these subcortical structures, meaning below the cortex of the brain. And it's reducing those obsessive and compulsive behaviors around food consumption. Now, it's approved for moderate to severe binge eating disorder, so not for mild binge eating disorder. That would be CBT or interpersonal therapy. And there is risk for abuse with this medication. As we know, it's an amphetamine drug, but it's definitely a little less risky in terms of abuse than some of the other medications used for ADHD. Now, people sometimes ask, could you use other stimulants in place of this? Yeah, you could, but the data, it doesn't really support it. So in theory, other stimulants could work as well as Vyvanse. However, Vyvanse is the one that's well studied and has the data to support its use. Now, you also want to screen for cardiac disease because, as we know, stimulants can cause some cardiac problems if they're either pre-existing or predisposed to them. The starting dose, you're going to start the patient at 30 milligrams per day, and you can increase by 20 milligrams per week to a target dose of somewhere between 50 and 70 milligrams. Most of the studies found that patients had response or remission somewhere between the dose range of 50 milligrams to 70 milligrams. It can be taken with or without food, and it should be taken in the morning and should not be taken at night, obviously to avoid the risk of insomnia associated with a stimulant being consumed at night. Makes sense, right? The response rates were actually quite excellent in binge eating disorder. So the response rates, defined as a 50% reduction in symptoms, is 86%, and the number needed to treat is 3. So number needed to treat is how many patients would I have to treat with the medication to see one good outcome, and that is only 3 patients. So this is very good. Anything less than 10 is considered good. Now, remission is defined as full remission of all symptoms. The patient has no symptoms. The remission rates were 40%, 40%, pretty good. These are high efficacy, these are highly effective medications. And the number needed to treat for remission was 4. So only one more patient was required to reach the remission. The number needed to treat for remission, rather. Side effects. People always want to know what the common side effects are. The most common side effect is actually dry mouth, which can be very disturbing to patients, and it actually does occur quite often. So it actually occurs in one time in every 4 patients that you prescribe the medication for. So it does occur often. Decreased appetite, as you can imagine, being on a stimulant will decrease your appetite. Insomnia, obviously being on a stimulant will keep you awake. You can also get headaches, constipation, nausea, irritability, and fatigue. So fatigue is kind of counterintuitive with a stimulant, but hey, it's one of the listed side effects. This medication, I want to point out, is not used for weight loss. So this is not, the goal of using the medication binge eating disorder is not for the patient to lose weight, although it does occur. So let's wrap the video here. Let's talk about the final points. So number 1, binge eating disorder, the most common eating disorder that we have. More men are going to be susceptible to this, although it's still a female predominance compared to other eating disorders. Certainly more men have binge eating disorders than in anorexia or bulimia. The other important points is there is FDA-approved treatment in the form of less dexamphetamine or Vyvanse, and there's also CBT and interpersonal therapy that can be used to treat the psychological components of the disorder. And you might want to combine both of those things for the maximum effect, although most of the studies looked at one or the other. We can actually help find and identify these patients by asking a very basic screening question. That question could be, has there ever been a time where you consumed more food than you intended to and felt out of control like you could not stop? That's a great way to screen for this. You can just ask that question, and if the answer is no, well, you don't have to ask any follow-up questions, but if the answer is yes, you might want to dig a little deeper because the likelihood that the patient is experiencing a binge eating disorder goes up if they say yes to a question like that. And you can add these questions in to your regular questions about appetite. So if I'm screening a depressed patient, I always ask about appetite anyway. I say, how has your appetite been lately? Has there ever been a time where you consumed more food than you intended to and felt like you couldn't stop? You can just filter it right into the basic interviewing style. You also want to be careful what type of language you use. I always say language matters in psychiatry, so you always want to avoid the terms fatness, excess fat, large size, heaviness, obesity, willpower. People don't want to hear about willpower when it comes to losing weight. You want to use terms like weight and BMI and avoid those other terms that can be negative and make people feel bad about their weight. So with that said, I'm going to end the video there. I appreciate you guys watching. And like I said, please like and subscribe to the channel. It helps me to keep going.